thank you very much for giving us the opportunity to share our work. This study is entitled Telomerase Activity as a Marker of Malignancy or Inflammation. As we know, telomerase activity is undetectable in normal mature somatic tissues, although low levels of TA have been found in normal proliferative tissues. High levels of et.al also have been reported in cancer cells from early stages of carcinogenesis. There is strong evidence that its activation is a critical event in the immortalization of human cells. Telomerase activity regulation is very complex and depends on many factors, among which we can mention age, ethnic group, hormones, virus, toxic habits, chronic inflammatory processes, and oxidative stress. In fact, there would be evidence that oxidative stress could increase telomerase activity, and all this would be implicated in the development of carcinogenesis. It is interesting to explore the relationship between telomerase, oxidative stress, and cancer. Nishikawa et al. Found that oxidative stress per se may increase TA. It was an in vitro study. So the following objectives were set. To determine telomerase activity in oral potentially malignant disorders and oral mucosal squamous cell carcinomas, to determine the concentration of tissue and salivary malondialdehyde in oral potentially malignant disorders and oral cancer as a marker of lipoperoxidation, to evaluate the antioxidant capacity through the dosage of superoxide dismutase enzyme and uric acid in saliva. It's interesting to remember that uric acid is responsible for 70% of the antioxidant capacity of saliva. To correlate TA with EMDA, salt and uric acid concentration, and to correlate TA with patient risk factors as tobacco, alcohol, mate, and chronic mechanical irritation. For this purpose, we developed the following material and methods. A case control study was carried out in Cordoba in patients of both genders over 18 years old who attended our service. 100 patients were divided as follows. 50 patients were included in the study group and 50, matched by sex and age with the previous one, were the control group. Was subdivided into two subgroups. One subgroup included patients diagnosed with oral potentially malignant disorders, and the other subgroup included patients diagnosed with oral cancer. The oral potentially malignant disorders group included 10 samples of oral leukoplakia and 20 oral lichen lesions and lichen plants. The oral cancer subgroup included 20 samples from patients diagnosed with squamous cell carcinoma of the oral mucosa. The following histopathological parameters were registered for the patients in the study group: presence or absence of inflammatory infiltrate, degree of epithelial dysplasia, and in case of carcinomas, degree of differentiation. Meanwhile, the control group included 50 patients matched by sex and age to patients in the study group with clinically and histopathological healthy mucosa. Pregnant patients, patients under 18 years old, patients with moderate or severe chronic periodontal disease, and all patients with any condition or pathology that could affect the telomerase activity per se were excluded from this study. We proceed to sign the informed consent form, to complete the clinical records, and perform the stomatological examination with special emphasis on the registration of the risk factors of the patient, habits such as smoking, drinking alcohol and mate, and the presence of chronic mechanical irritation. Regarding this, we proceed to the detailed recording of the variable chronic mechanical irritation of the oral mucosa, following the criteria of Piemonte et al. CMA 0 in the absence of CMI, and CMA 1 presence of CMI in relation to the lesion. Buccal saliva was collected to determine biomarkers of oxidative stress. The determination of salivary MDA was performed using the T-bars method by Okawa et al. Determination of salivary sod activity by the method of McCart and Friedovich, and salivary uric acid was determined using the WAPAP triangle color enzymatic method of Principe et al. The biopsy was then carried out and subdivided into 4 fragments. Fragment A for histopathological diagnosis, fragment B for the determination of telomerase activity, fragment C for the determination of tissue MDA, and fragment D for HBV detection. For the determination of telomerase activity, we carried out a type of PCR called trap PCR, telomerase repeat amplification protocol, by Kim et al., followed by ELISA. The TA variable was categorized as follows: 80 as negative, 81 positive, weak, 82 positive, intense. Statistical analysis. A p-value less than 0.05 was established for significant differences. All data were performed with InfoStat professional. Results. Regarding the characterization of the sample, 60% were female patients and 40% male. TI determination in tissue samples of study and control group. We can clearly see that 82% of the samples from the study group presented positive telomerase activity compared to only 24% of samples with positive telomerase activity from the control group. So we can say that statistically significant differences were observed in the expression of TA between the study group and the control group, with a p less than 0.0001. In the same way, statistically significant differences were observed in TA depending on the stomatological pathology analyzed, finding a greater number of cases of positive TA in patients with oral cancer, followed by ligand-liganoid group, and finally oral leukoplakias. Regarding the correlation of TA with different clinical and histopathological parameters, we can say that in our study, we did not find a relationship between TA and sex, age, biopsy site, or patient habits such as smoking, drinking alcohol, or drinking mate. A relationship was found between TA and the degree of differentiation of the carcinomas. The poor differentiation, a higher TA intensity was found. Likewise, statistically significant differences were found between TA and the presence of dysplasia and inflammatory infiltrate. Something that caught our attention was the relationship found between TA and the presence of chronic mechanical irritation, both in the patient of the study group and in those of the control group, with the p equal to 0.0006. In relation to oxidative stress biomarkers, we can state that higher concentrations of salivary and tissue MDA were found in the patients of the study group compared to those of the control group. Increased salivary salt activity was observed in study group patients compared to control group patients. A marked decrease in salivary uric acid concentration was also observed in the study group. We also found a relationship between salivary and tissue MDA concentrations and TA intensity. The higher the concentration of MDA, the higher the TA. Finally, we also found a relationship between the activity of salivary salt and the intensity of TA. The greater the activity of salt, the greater the intensity of TA. A relationship between uric acid concentration and TA intensity was observed. The lower the concentration of uric acid, the higher the intensity of TA. Remember that uric acid behaves as the main antioxidant in saliva. There could be many relevant aspects to discuss in this work, but for reason of times, we'll focus on the trigger that generated the initial question about the relationship between TA and inflammation, trying to relate the findings regarding TMI, inflammation, and cancer. In fact, several studies, such as the ones by Ferrer or et.al., show that chronic inflammatory processes produce an increase in the concentration of ROS. Among other effects, free oxygen radicals have the ability to induce apoptosis, neoangiogenesis, and damage at the level of genetic material that could be involved in the development of carcinogenesis. In this sense, our previous findings, based on the relationship between TA and CMI, allow us to think that the factors that generate CMA at oral mucosa produce a state of persistent chronic inflammation with increased ROS and generation of oxidative stress at oral cavity that would cause a reactivation in telomerase activity, favoring the development of oral carcinogenesis. Conclusions. The present work confirms the author's findings that TA is associated with cancer. No relationship was found between TA and the presence of toxic habits. Elevated TA levels were significantly associated with the presence of CMI, probably due to the underlying chronic inflammatory process. The oxidative stress markers analyzed would model ITA in the oral cavity. Of course, further studies are needed, especially in oral potential malignant disorders. And the findings of this study may be useful as a key to the indication of dental treatments that reduce local irritants and also reduce inflammation, thus contributing to improve health, especially in patients with oral potentially malignant disorders. That's all. Thank you very much.
My name is Carolina de Carvalho, and I'm a scientist at the Genomic Epidemiology branch of the International Agency for Research on Cancer. I'm going to talk about plasma detection of HPV-16 DNA in oropharyngeal squamous cell carcinoma patients for the prognostication and post-treatment monitoring of these patients. Oropharyngeal squamous cell carcinomas are tumors that affect mainly the tonsils, the base of tongue, and the soft palate. This is one of the most affected sites in the head and neck cancer region and is associated with high incidence and mortality rates. Despite the decrease in the incidence of tobacco-associated cancers over the past several decades, the incidence of oropharyngeal cancer cases has steadily increased. This has been attributed to increases in high-risk human papillomavirus-driven disease caused mainly by HPV-16 type. HPV positivity has an important clinical impact in oropharyngeal cancer patients, and these cases are usually associated with a reduced risk of death and an improved overall and disease-free survival in comparison to HPV-negative cases. However, 13 to 25% of these HPV-positive patients still develop recurrent disease or distant metastases within 2 years of follow-up, and this can go up to 36% when we consider up to 8 years of follow-up. So the current challenges on the management of these patients are the lack of strategies for precision therapy, since current treatment regimens do not differ according to HPV status, and HPV-positive patients are still treated with aggressive multimodality regimens. The disease monitoring is inefficient, so physical and imaging examinations frequently fail to detect asymptomatic lesions, and this delays salvage treatment and reduces chances of cure. And the assessment of prognosis and treatment response is inaccurate, so there is still no clinical feature or biological marker that can accurately predict treatment failure and or likelihood of recurrence or distant metastasis in these tumors. So we think that body fluids can be an important source of tumor-derived molecular information, and in this case, we believe that the detection and monitoring of HPV ctDNA in plasma samples of oropharyngeal cancer patients can be useful as a non-invasive approach for serial sampling during patient management, as a complement physical and imaging exams to improve patient stratification and surveillance by more accurately reflecting changes in tumor burden, and also to improve selection of patients for the intensified treatment regimen. So there are different methods available for liquid biopsy, and we decided to go for digital PCR because it's a method that allows for absolute quantification. It requires a low input of DNA, and it seems to be more feasible to be applied in the clinical practice if we find that this is interesting results. So other studies have already tested this approach, so detecting HPV ctDNA in droplet digital PCR sample. Using droplet digital PCR, and they have shown that there seems to be an association between HPV ctDNA levels with T and N stage, and it seems to be feasible to detect HPV circulating in the plasma samples even from those patients with very small tumors or asymptomatic disease, and the detection of HPV ctDNA in plasma samples collected after treatment seems to be associated with worse disease-free survival. So given this background, our study objectives are to determine the sensitivity and specificity of detecting HPV-16 E6 ctDNA using droplet digital PCR in plasma samples, baseline plasma samples from oropharyngeal cancer patients, to evaluate for associations between the plasma samples, the levels and the status of HPV ctDNA in these plasma samples evaluated at baseline with clinical information from these patients, And in the future, I'm now going to show data related to objective 3. I would like to see if the levels of HPV ctDNA in plasma samples collected after treatment, if this has any correlation with total tumor burden, with treatment response, or disease outcome. So in terms of study population, we are going to evaluate samples from 3 countries in South America and 7 countries in Europe. All these samples are either oropharyngeal cancer cases or healthy controls. They have HPV serology data generated as part of these studies, but mainly as part of Headspace. And all these patients, they have baseline plasma samples, and these were collected as part of the interchange and ARCADE study. So moving on with the results, we selected 177 plasma samples from these patients, and 19 of them failed QC either during cell-free DNA extraction or the GPCR reactions. And I'm going to show today the results from 158 samples with valid HPV ctDNA measurements. Out of these 158 cases, 75 were oropharyngeal cancer patients with HPV-16E6 serology positive. 26 of them were also from oropharyngeal cancer patients, but these patients were HPV-16E6 serology negative. And 57 of these patients, of these samples, were from healthy controls, and these were all serology negative cases. This slide shows this graph with the levels of HPV ctDNA in plasma samples from healthy controls, from HPV negative oropharyngeal cancer patients, and from HPV positive oropharyngeal. And we were able to observe a sensitivity of 92% and a specificity of 96.4%. In terms of the association with different variables, here we have the first results trying to see if there is any association between HPV ctDNA levels and demographic variables. And as expected, we didn't find any differences according to gender, according to region. So here we have those samples from Europe and samples from South America. And there was also no difference according to age at diagnosis. The next analysis was to see if there would be any association with different clinical variables, and we did not find any association with cancer subsite, nor with clinical T stage, but we did find an interesting increase in the HPV ctDNA levels according to end stage. So those patients with a higher burden in the N category of the TNM showed an increased level of HPV ctDNA, and this was statistically significant. So finally, our last analysis was on the association between these levels of HPV DNA detected in baseline plasma samples with overall survival. And we observed that those cases with detectable HPV ctDNA in these baseline plasma samples had a better overall survival in comparison to those cases with undetectable HPV levels. And this was confirmed even after adjusting by different variables. Only HPV-16 HPV ctDNA status was associated with a reduced risk for death in this case series we analyzed in this study. So in conclusion, this is the first study to detect and evaluate the impact of HPV-16E6 ctDNA status and level in plasma samples from oropharyngeal cancer patients from South America. The approach used showed a very high sensitivity and specificity when comparing to data from HPV-16E6 serology from the same patients. And we were able to confirm the association of the detection of HPV-16 ctDNA with clinical end stage and overall survival. So in terms of next steps, we're going to expand the case series evaluated at baseline with prospectively collected cases from Headspace. We will try to analyze the association of the HPV ctDNA levels with disease-free survival. We evaluate the plasma samples collected after treatment and during patient follow-up to test for associations between the persistence or increased decrease of the HPV-16E6 levels with response to treatment and disease outcome. And we're also going to initiate a pilot study with colleagues from Centre Léon Bérard in Lyon for the evaluation of normal tumor, total tumor volume and test for correlations with HPV-16 ctDNA levels. So I'd like to thank all the help and support from my colleagues at IARC, the team in DKFZ that was responsible for generating the data for serology, our colleagues from INSERM and CLB that have been very important in the new steps, especially regarding the collecting of imaging data to assess tumor volume. All participants, all patients and institutions collaborating with the recruitment of patients and collection of data for the Headspace, Interchange and ARC-Age studies, and the funders, so the Institut National du Cancer in France and the European Union for the support for Headspace. Thank you very much.
Yes. Hi, Evelyn. Did you control or at least ask for the temperature of the mate of the patients, because they will induce a lot of ROS if they are very hot, and then they may...
Yes, it was subjective. We didn't measure as an objective way the temperature of the mate. We just asked the patients and they tell us if they took mate hot, very hot, but it was a sensation of the patient. It was not an objective measurement.
Okay, thank you.
Carol, you use the Biomarkers system for the ddPCR, right?
Yes, that's right.
Now, the trouble that we kept having with that system is that you basically, when you go to relatively low numbers of positive droplets, then you have this effect called rain between the positives and the negatives. So it gets sort of actually difficult to really determine what do I still count as positive and what do I consider negative. And then we had the trouble that we ran into these classical cutoff problems, basically defining a cutoff that gave us a binary answer for something that looked more like a continuum. How did you solve that?
Yeah, we used to have this rain effect when we were analyzing tumor samples when I was back in Barretos. But to be honest, with the plasma samples for HPV, we didn't have it as much. I think because the volumes were small and maybe the copy numbers was not very low, so we had few droplets. And for some cases, of course, we had quite a few droplets when the viral load was higher. But I never saw so much of the rainfall thing. And in terms of the cutoff, what we did, we always had negative cell lines. And first, for us to determine the different channels, so we can, in the 2D plots, we always used it considering the HPV positive and the HPV negative controls. So first, we set the scores, the thresholds using the cell lines, and then considering that cutoff, we used it to see where above which threshold those droplets would be considered positive or not. But usually they were quite high. Even for those cases with very few droplets, they tended to be quite high from that noise, the negative droplets at the bottom, yeah.
Okay, cool. Thanks.
Maybe just another one for Carol, because clearly the sensitivity and specificity is kind of extremely impressive, but that depends a little bit on your gold standard as well, which I guess comes from Tim. And I just wanted to ask in particular about one individual that was HPV ctDNA positive. It was one of the cancer controls, yet kind of, I guess, serology negative. I mean, because the alternative explanation is that the serology got it wrong and that the ctDNA got it right. So what do you think?
Yeah, for this case, I even included here the information because I knew someone was going to ask about it, because my target, my probe, is specifically for E6, right? And this specific case was E6 negative, but it was positive for E1, E2, and E7. So I don't know. What do you think?
Well, this is funny because I was going to tell this tomorrow. We know that the E6 serology, when we use a really good gold standard for HPV-driven tumors, HPV-driven oropharynx cancers, such as P16+-ish, or presence of HPV RNA in the tumor. The E6 serology has a sensitivity, we meta-analyzed that recently, of about 90%. It's far from being perfect, right? So yes, that does happen that there are, that we miss HPV-driven tumors with the E6 only serology. It was always our understanding in Heidelberg that multiple seropositivity for other E antibodies was meaningful, even in people who were E6 negative, that triple positivity for E1, E2, E7, that was meaningful. That was always based on gut feeling more than evidence, right? But still it was good enough for us to include this as a definition in Voyager. It only gives us, say, 1% extra sensitivity. We just got, say, the confirmation from our screening study in Hamburg. We just had another case positive, a woman who was for about 2.5 years in clinical follow-up, who was just diagnosed with a P16 positive lymph node, and she had her panendoscopy today and was found with a small tonsillar cancer. And she does not have E6 antibodies, but E1, E2, E7 antibodies. So I consider that it's only a single case for a single % sensitivity, but I consider that the confirmation that is actually meaningful. So I would actually count that as HPV serology positive case.
Yeah, that's why I considered it. I could just ignore it, but I think we don't have the P16 data from this case yet, but I don't know, maybe eventually we will, and then we can have another level of confirmation for either one of the methods. Yeah. Okay. So I think it's probably a very similar answer to Camilla's. So I think we have two possible applications for these different methods in liquid biopsy and specifically for HPV. The first one is to try to better classify these patients according to their outcome and also how they respond to therapy. So we can maybe improve the management of these patients, choose which ones might be able to have an intensification of the treatment and other adjustments in the protocol of managing these patients. And the second point is to be able to help in the surveillance after the treatment, because we know that the imaging exams or the other the strategies used during the follow-up of these patients usually need the lesion to be either causing a symptom or very detectable. So it makes it more difficult to be able to detect them early. And so I think that the use of these biological markers might improve this early detection using less invasive methods and a method that could be used at several moments during the follow-up of these patients, and the doctors might be able to act faster and earlier and maybe improve the chances of cure.